Hi everyone, welcome to NURS 2020 Advanced Pathophysiology and Microbiology. In this lesson we're going to focus on Unit 3, the Neurological Disorders. Here's the content that we're going to be going through. We'll discuss ICP, or intracranial pressure, in great detail. And yes, the Glasgow Coma Scale is the scale that's used to assess for functioning in terms of neurological functioning, especially in terms of clients with increased ICP. We'll then move on to hydrocephalus, TBIs, or traumatic brain injuries. We'll discuss stroke, CNS infections such as meningitis, seizure disorders, and then we'll switch gears and discuss dementia and delirium with a specific focus on Alzheimer's disease, and then move on to Parkinson's disease, multiple sclerosis, and close off with ALS, or amyotrophic lateral sclerosis. Please remember to read through the slide deck for Unit 3 as well as all the other learning resources that are posted on the Blackboard shell. Intracranial pressure, or ICP for short, is the pressure within the cranial cavity. If you remember from E&P, the cranial cavity consists of the brain, CSF, and blood. If either of those three components increases in volume, then ICP is going to be raised. Consequently, a raised intracranial pressure or raised ICP may be present in various serious neurological conditions, including head trauma where there's bleeding, intracranial hemorrhage where there's bleeding into the brain due to a rupture of a cerebral artery, for example, a brain tumor, which is a mass effect, cerebral edema, which is the fluid exudation from the capillaries, and so forth. Essentially, if there's an increase in the mass of the brain, if there's an increase in the CSF, and or an increase in the blood or blood flow, then intracranial pressure is going to increase. If ICP is raised and cannot be lowered, so it's intractable, that invariably will lead to death because it will reduce cerebral perfusion. So let me discuss that a little bit. There are three components, as we mentioned. If, say, that there is a brain tumor, for example, or if there's an increase in CSF, cerebrospinal fluid, then one of the other components has to decrease in order to keep ICP in the normal range. And usually, since blood flow can be regulated far more easily compared to the brain mass, which you can't really change, or the CSF, or cerebrospinal fluid, it's really the blood flow that gets altered if there's an increase in brain mass or if there's an increase in CSF volume. So that's what this statement means. So if there's an increase in ICP, for example, let's say a brain tumor or cerebral edema, then cerebral perfusion will decrease because you want to reduce the flow of blood to the brain in order to reduce one of those three components, which is blood. Unfortunately, however, a reduction in cerebral perfusion will cause cerebral ischemia, and that in turn can cause necrosis of brain tissue. The other way that the raised ICP can cause death is just simply by the compression effect. So if, say, for example, there's brain hemorrhage, then simply the raised ICP due to the intracranial hemorrhage will start compressing the brain and can eventually cause brain herniation. The brain can literally be squeezed out through the openings in the skull, especially the foramen magnum, and that will invariably cause compression of the brainstem and death. An elevated or raised ICP is associated with a 20% mortality rate, so that's extremely high. Consequently, identifying quickly the clinical manifestations of a raised ICP is absolutely essential for a nurse. It is vital in terms of being able to identify it and then providing the adequate treatment in order to reduce the ICP. Otherwise, what's going to happen? Cerebral ischemia will occur due to a decrease in cerebral perfusion, and in addition, there's a risk of brain herniation. By the way, the normal ICP range in adults is between 10 to 15, really should be slightly less than 10 to 15 millimeters of mercury. So what are the etiologies of a raised ICP? We've already alluded to that. Any localized mass lesion, for example, an epidural or subdural hematoma from trauma to the skull, can cause an increase in ICP. In addition, intracerebral hemorrhage, which we've already discussed, that would be a hemorrhagic stroke, for example, and various brain tumors or neoplasms. So this is the mass effect. We're literally increasing the mass of the brain either through introduction of blood or through the growth of a brain tumor. The other way is through an increase in CSF or cerebrospinal fluid. That would be hydrocephalus. So an increase in the normal amount of CSF beyond the normal amount is termed hydrocephalus, and that's going to increase ICP. Lastly, we have diffuse brain edema. So if you have edema that is widespread, for example, during the course of severe bacterial meningitis or inflammation caused by a subarachnoid hemorrhage or encephalopathy, then that's going to increase the water content in the brain, and consequently it's going to increase ICP. More importantly are recognizing the clinical manifestations of a raised ICP. The hallmark clinical manifestations of a raised ICP is a deteriorating level of consciousness. In addition, there is a deteriorating respiratory pattern, which is part of the Cushing's reflex that we'll see. The theory behind that is that the increasing pressure alters the activity of the respiratory centers in the brainstem that causes the very irregular breathing pattern. The Cushing's reflex was identified many years ago and is used to identify a raised ICP, but unfortunately the Cushing's reflex is only present during the terminal stages of a raised ICP, so shouldn't rely on that exclusively. There are brain monitors, ICP monitors, that can directly measure ICP, although it is really invasive. You have to drill a hole and insert a pressure transducer into the brain in order to directly measure ICP. Let's talk about the Cushing's reflex in a little bit more detail. And the Cushing reflex consists of hypertension, bradycardia, and irregular respirations. The irregular respirations, we already mentioned, that's probably due to the altered activity of the respiratory centers in the brainstem, and that's a really late effect. So that occurs more or less towards the end. The other two, hypertension and bradycardia, actually seem paradoxical. Usually you have hypertension and tachycardia, or hypotension and bradycardia. Here we have hypertension and bradycardia, which seem to be diametrically opposed to each other. So let's try to explain that. When you have a raised ICP, one of the first things that occurs is that the pressure of the cerebrospinal fluid increases. And then the pressure increases such, because of the compression effect, when the pressure of the CSF increases beyond a certain point, it causes the reduction in blood flow because it is increased beyond the mean arterial pressure, or MAP. Consequently, there's a reduction of blood flow to the brain. The body recognizes that and tries to compensate for it by activating the sympathetic nervous system initially. The sympathetic nervous system will cause systemic contraction, vasocontractions of the capillaries and arterioles, thereby causing hypertension. The hypertension is there in order to increase the blood flow to the brain, since the pressure of the CSF has exceeded the mean arterial pressure. So you're trying to increase the blood pressure in order to get more blood to the brain to prevent ischemia. So in that manner, activation of the sympathetic nervous system, we can explain the hypertension. However, the hypertension in turn then you would anticipate cause tachycardia because of activation of the sympathetic nervous system. But it turns out, and this is where it gets a little bit confusing, that yes, initially the sympathetic nervous system is activated, but eventually the parasympathetic nervous system is also activated, and that reduces the heart rate, causing bradycardia. So the Cushing's reflex consists of hypertension, bradycardia, and then at the later stages, the irregular respirations as well. As the pressure continues to rise, you get these lateralizing CNS signs. So lateralizing means that it affects the lateral parts of the cranial nerves, right? The cranial nerves, the term is a bit odd, but the cranial nerves we know are paired and affect the lateral parts of the body, right? The two eyes, etc. So when you have these lateralizing signs, it's just what it means is that it causes various palsies of the cranial nerves and hemiparesis as well. A headache, nausea, and vomiting when the vomiting center in the brainstem is affected. Pupillary dilation is due to the so-called lateralizing sign when cranial nerve 3, 4, 6 is affected, and then you have bilateral ptosis as well. As the pressure continues to rise, then you have these phenomena of the extension to pain. That's the decerebrate and decorticate positioning that the individual ultimately adopts over there. Lastly, we have seizures and papilledema as well. So there's a whole variety of different clinical manifestations, but please remember that the hallmark clinical manifestation is a deteriorating level of consciousness. If there is a history of head trauma, or if ICP is suspected to be raised, then yes, level of consciousness needs to be assessed. And also perhaps the other clinical manifestations that you want to focus upon is this Cushing reflex and the cranial nerve palsies. Let's now discuss hydrocephalus. Hydrocephalus is the excessive accumulation of cerebrospinal fluid, or CSF, in the brain. If you remember from your A&P, CSF circulates in the ventricle that's produced by the choroid plexus and then drains through the subarachnoid granulations. There are two types of hydrocephalus, the obstructive or non-communicating variant and the non-obstructive or communicating variant. Sounds confusing, but we'll explain it. The obstructive or non-communicating hydrocephalus is when CSF circulation is blocked proximal to the arachnoid granulation. In other words, the CSF cannot circulate freely through the ventricles, from the lateral ventricles to the third ventricles to the fourth ventricles and into the subarachnoid space to be drained through the arachnoid granulation. If the CSF cannot flow through either of the ventricles, then it is classified as obstructive or non-communicating hydrocephalus. That makes sense because the flow of CSF from, let's say, the lateral ventricle, let's actually go with the third ventricle to the fourth ventricle, if it's obstructed, then because of a blockage in, say, the cerebral aqueduct, if you again remember your A&P, then yes, that makes sense. It's obstructive hydrocephalus, or non-communicating because the ventricles are not in communication with each other. So the etiology of obstructive or non-communicating hydrocephalus is any lesion, a tumor, a hematoma, that blocks the flow of CSF from one ventricle to the next, or stenosis of the cerebral aqueduct that connects the third and fourth ventricle. Consequently, the ventricles that are proximal to the site of the blockage become dilated. So CSF, say, between the third and fourth ventricle is not able to flow properly, the third ventricle is going to get dilated if there is stenosis of the cerebral aqueduct. In non-obstructive or communicating hydrocephalus, the CSF can circulate through the ventricles, but it is not absorbed at the arachnoid granulation. So absorption is blocked at the arachnoid granulation. The etiology of non-obstructive or communicating hydrocephalus is a post-infectious condition whereby the inflammation damages the ability of the arachnoid granulations to absorb the CSF into the venous circulation. Another etiology might be post-hemorrhagic, whereby there is bleeding into the subarachnoid space and then the blood clots and blocks the arachnoid granulation. The way you distinguish between obstructive and non-obstructive hydrocephalus is that in obstructive hydrocephalus, the ventricles that are proximal to the site of the blockage become dilated, whereas in non-obstructive hydrocephalus, all the ventricles are dilated because the CSF is not being absorbed through the arachnoid granulations. The clinical manifestations of hydrocephalus are, yes, raised ICP. We saw that's the etiology of raised ICP. One of the etiologies of a raised ICP is hydrocephalus. Consequently, the clinical manifestations of hydrocephalus are all really exactly the same as the clinical manifestations of a raised ICP. We have a headache, nausea, vomiting, the hallmark clinical manifestation of a raised ICP being a decreased level of consciousness, decreased cognition, diplopia, that's the so-called lateralizing CNS signs, difficulty in walking, and so forth. Perhaps the motor cortex is affected as well. So the bottom line is that the clinical manifestations of hydrocephalus are all related to raised ICP. Let's switch gears now and discuss traumatic brain injury, or TBI for short. Approximately 1.7 million deaths, hospitalization, and emergency department visits each year to the US are due to TBI. If you divide those numbers by 10, that would be the numbers roughly in Canada. Fortunately, 75% of traumatic brain injuries are estimated to be mild. So I know it seems odd to say and use the word mild when we are discussing traumatic brain injury, but in this particular case, mild means that there is potential for recovery of the various brain functions whereas a moderate to severe traumatic brain injury has a rather poor prognosis. Nevertheless, 25% of 1.7 million, and that's quite a bit. So traumatic brain injury is something that needs to be discussed and needs to be avoided at all costs because it has a very high toll that it exacts on the individual who has developed a traumatic brain injury. The highest incidence of TBIs are in children 0 to 4. That might not surprise you considering the number of accidents that occur in that age group. In adolescents, especially in adolescent males, due to the increased risk-taking activities, and in the elderly greater than 65 years, the assumption here being is that most of the TBIs in the elderly are due to falls. The clinical manifestations of a traumatic brain injury are again all due to, or most of them are due to, an increase in the intracranial pressure. So we have headaches, sleep disturbances, nausea and vomiting, blurred vision due to the lateralizing CNS signs. In addition, you can have cognitive dysfunctions if the frontal lobe is affected, attentional impairment, or if it is a milder form of a traumatic brain injury. Attentional impairment, reduced thinking speeds, processing speeds, drowsiness, all the way to amnesia. There can also be more subtle signs such as emotional and behavioral disturbances. Increased irritability might be the only clinical manifestation of a mild traumatic brain injury. In a severe concussion, that in turn is a form of a traumatic brain injury, and that may precipitate seizures, bradycardia, hypotension, and sluggish pupils. Let's discuss the pathogenesis of a traumatic brain injury in more detail. Firstly, there is a primary impact injury, so injury to the site of the primary impact. If it is a low velocity impact, then there's usually just local damage. Probably shouldn't use the word just, but there's local damage because of low velocity. In a high velocity impact, there can be distant damage, distant meaning away from the site of the impact. Distant damage to the brain is also possible. We should do a few definitions as well. A concussion is a trauma-induced alteration in the mental status. However, there is no parenchymal, no abnormalities that are noted on the CT scan. If there are any abnormalities, such as bleeding, then it cannot be classified as a concussion. So a concussion is based upon the clinical manifestations, but there has to be normal imaging studies. Usually imaging studies are not done if it is a milder form of a concussion because the clinical manifestations alone lead the healthcare provider to make that diagnosis without the necessity of extensive brain imaging, for example. A coup injury is when there is in the case of the coup injury, is the damage at the site of the blow, and then coup is when there is damage at the opposite side of the blow. The classic case being a motor vehicle accident, whereby if you're not wearing a seatbelt, your head hits the windshield, so you're going to have an injury on the frontal lobe of your brain, but then your brain rattles back and hits the back of your skull, and then you can have an injury or a contusion or even bleeding. It's something more severe than a contusion in the occipital lobe. So that's a coup injury. A contusion or a brain contusion is a localized area of hemorrhage. So if the hemorrhage is widespread, it's not just a contusion. A contusion is just a localized area of bleeding or hemorrhage in the brain. So if there is evidence of a contusion, then it cannot be a concussion. Remember, a concussion shows no parenchymal abnormalities on brain imaging. Lastly, diffuse axonal injury or shearing is when you have widespread damage to the neurons in the brain. So you have widespread rattling of the brain, for example, in the cranial cavity, and literally the axons of the neurons in the brain get torn, and that's why it's referred to as diffuse axonal injury or shearing. That's going to be a very severe form of traumatic brain injury. Unfortunately, it's not only the primary impact or the primary area of impact that poses severe problems in a traumatic brain injury. They can also be secondary pathological processes, and in some cases the secondary processes are even more severe than the primary processes. What are the secondary pathological processes that are associated with a more severe form of a traumatic brain injury? Cerebral edema being the key one. So remember, in any injury you're going to have inflammation, and inflammation is going to increase the permeability of the capillaries. Now you have increased fluid exudation, resulting in, and if it's a diffuse injury, you're going to have widespread cerebral edema. The widespread cerebral edema in turn will increase the ICP, and now you have a vicious cycle that is developing. In addition, the diffuse injury to the axons can also trigger this so-called cytotoxic cascade. So glutamate is the main excitatory neurotransmitter that is utilized in the brain, and when you have neuronal injury, you have glutamate release, and glutamate outside of the synapse is a highly toxic substance. You can have the cytotoxic cascade developing that causes further injury. Intracranial hemorrhage will increase the ICP further, causing and increasing the risk of brain herniation, for example. As we mentioned previously when explaining the Cushing's triad or reflex, you can have cerebral ischemia developing. So as ICP increases, the pressure of the CSF increases, and when the pressure of the CSF increases beyond the mean arterial pressure, then ischemia will develop due to the fact that cerebral perfusion will decrease. Right? Cerebral perfusion has to be at a pressure greater than the mean arterial pressure in order for blood to be perfused into the brain, and when ICP is increasing, and if cerebral perfusion pressure doesn't increase, then ischemia will result. Where he spoke about the risk and all the clinical manifestations of ICP, along with the risk of developing hydrocephalus as well. So these are all the secondary pathological processes, not just the injury to the original site of the insult, say a blow to the head. That's the primary process, but the secondary pathological processes can make the injury, the traumatic brain injury, far more worse. We previously classified TBIs as mild, moderate, and severe. That's all based upon the GCS score. So mild TBIs have a GCS scores of 13 to 15. And what would the outcomes be for a mild TBI? You have post-concussive symptoms, headaches, dizziness, nausea, blurred vision, diplopia, memory impairment, tinnitus, and low concentration. That doesn't really sound mild, but nevertheless, that is what we mean by a mild TBI. It's still the clinical manifestations of even a mild TBI, you can see, are pretty significant. In a moderate case of a TBI, we have a GCS score of 9 to 12. The outcomes are all related to age and the CT findings. So there has to be a determination about how much of the brain has actually been damaged. 7% of individuals, for example, can be in a vegetative state or even ultimately progress to death, and 30% or so will ultimately be moderately to severely disabled, and that's just a moderately traumatic TBI. In a case of a severe TBI where the GCS score is less than 8, it has an extremely high mortality, but otherwise the outcomes are difficult to predict. It depends upon whether treatment can be initiated immediately, it depends upon whether surgery is an option, and so forth. Next, let's discuss the 4 different types of TBIs: epidural hematomas, subdural hematomas, subarachnoid hemorrhage, and intracerebral hemorrhage. An epidural hematoma is pooling of blood between the skull and the dura. Epi means above, and in this case it's above the dura. The etiology is typically a skull fracture, so a blunt force trauma to one of the cranial bones, usually the temporal or parietal bones, because they are the thinnest of the bones in the skull. The pathogenesis is the rupture of the meningeal arteries that are located in the dura. Consequently, remember, it's an arterial bleed, which is much faster compared to a venous bleed. The clinical manifestations of an epidural hematoma is the initial post-traumatic reduced level of consciousness. So after the skull trauma, you have a reduced level of consciousness. However, a few minutes after that, there is a lucid interval that develops that can last between 1 to several hours, and then after those several hours, there's a rapid decline in the level of consciousness. So how do we explain this? So the initial blow rattles the brain, and you have that reduced level of consciousness. Now, because, and let's assume that it is not a very severe bleed immediately where several arteries have got ruptured and so forth, yes, you have the start of a bleed, the arterial bleed, but let's assume it's limited in scope. So eventually the brain will recover, and now you have this lucid interval of several hours. But because it's an arterial bleed, the blood starts to pool in that area, and then once it reaches a certain size, which will increase the ICP. So what we're really referring to here is that the initial reduction in the level of consciousness is due to the blow, say from a baseball bat or whatever the case might be, and then you recover, but now you have this arterial bleed, and the arterial bleed is going to cause ultimately a decrease in the level of consciousness due to an increase in the ICP. So eventually, once ICP increases to a certain level, beyond that threshold, there's a rapid decline in the level of consciousness. We've covered this already. The rest of the clinical manifestations are all related to the increase in the ICP. Headache, nausea, vomiting, amnesia, seizures, respiratory distress, perhaps the Cushing's, reflex of hypertension, bradycardia, and respiratory irregularities, all the way to ultimately coma and death. Subdural hematoma, on the other hand, is the pooling of blood between the dura and the arachnoid mater. It occurs as a consequence of the rupture of the bridging veins in the region. In other words, it's a venous bleed as opposed to an arterial bleed. The risk factors for the development of a subdural hematoma include head trauma, for example, falls in the elderly. So you might say at this stage, how is this different from an epidural hematoma? Usually the head trauma is less severe compared to the head trauma that results in a epidural hematoma. So it usually doesn't cause a skull fracture. If there's a skull fracture, then almost invariably there's a much greater increased risk of a epidural hematoma. Here is it, how should we put this? It's a less than traumatic type of head trauma, so there might not even be any visible injuries. The classic example are falls in the elderly, shaken baby syndrome can also cause a subdural hematoma in those infants. The clinical manifestations of a subdural hematoma are actually quite variable depending upon the severity of the bleed and whether it is an acute or chronic condition. Acute being 1 to 2 days post-bleeding onset, or chronic being 15 days post-bleeding onset. It can be a chronic subdural hematoma because remember, this is a venous bleed that develops slowly. It's not like an epidural hematoma whereby the pooling of the blood occurs rather quickly because it's in the arterial bleed. In the case of an acute subdural hematoma, potentially the only clinical manifestation is an altered level of consciousness. Otherwise, pupillary irregularities and hemiparesis can also develop depending upon the exact extent of the bleed. Subarachnoid hemorrhage, on the other hand, is bleeding into the subarachnoid space that is normally filled with cerebrospinal fluid. The etiology of a subarachnoid hemorrhage is the rupture of a cerebral aneurysm, for example, a Berry aneurysm in the circle of Willis, or the rupture of an arteriovenous malformation, AVM for short. The clinical manifestations of a subarachnoid hemorrhage are very different from those of an epidural hematoma or a subdural hematoma. The classic clinical manifestations are the sudden onset of an extremely severe headache, usually described as the worst headache of my life. Other clinical manifestations include nausea and vomiting, signs and symptoms of meningeal irritation, which are going to be similar to bacterial meningitis, which we'll be discussing shortly. For example, photophobia and visual changes that are classic in bacterial meningitis. There can also be other focal neurological deficits along with seizures, hydrocephalus, and cardiovascular dysfunction. Before we discuss intracerebral hemorrhage, which is the fourth type of a traumatic brain injury, we're going to discuss strokes more generally speaking. So what is the definition of a stroke? Stroke is a sudden onset of neurological deficits due to a vascular etiology with infarction of the CNS tissue. And remember, infarction is permanent tissue damage or evidence of permanent tissue damage. On the other hand, a transient ischemic attack or TIA is when you have a sudden onset of neurological deficit but it is transient, so it resolves within 24 hours, caused by a vascular etiology, so a reduction in blood supply due to atherosclerosis, for example, but there is no evidence of infarction. In other words, brain imaging studies via CT or MRI doesn't show any evidence of infarction, and the symptoms have resolved within a day, then you can classify it as a transient ischemic attack. Whereas in a stroke, the symptoms typically last longer than 24 hours, and there is evidence of an infarction on brain imaging studies. There are two types of strokes: an ischemic strokes, which makes up 80% of all strokes, and hemorrhagic strokes, which make up the remaining 20%. And we can subdivide the hemorrhagic strokes into a subarachnoid hemorrhage that we just previously discussed and intracerebral hemorrhage. They make up approximately half each of the hemorrhagic strokes. What are the risk factors for a stroke? Age, especially greater than 60 years of age, hypertension, diabetes mellitus, atrial fibrillation, hypercholesterolemia, smoking, lack of physical activity, and/or sedentary lifestyle. All these risk factors are similar to the risk factors for coronary artery disease, which is not a surprise. Let's discuss ischemic strokes in more detail. There are two types of ischemic strokes: thrombotic strokes, which makes up 4/5 of all types of ischemic strokes, and embolic strokes. A thrombotic stroke is when an arterial thrombus forms in a large vessel, in which case the risk factors are atherosclerosis, or in a smaller vessel, in which case the main risk factors are hypertension and diabetes mellitus. The symptoms of a thrombotic stroke, if we want to compare it to an embolic stroke, typically progresses over several hours to days, and typically occurs, the clinical manifestations, the signs and symptoms typically develop while sleeping. The neurological deficits gradually progress overall in a stepwise manner. In other words, they don't suddenly appear in terms of being very severe all of a sudden. There has to be a gradual progression, and that is indicative of a thrombotic stroke. An embolic stroke, as we'll see on the other hand, typically occurs very quickly, and it typically occurs while the individual is awake. In terms of the prior medical history for a thrombotic stroke, usually the client or patient has prior evidence of transient ischemic attack. And remember, transient ischemic attacks is when the clinical manifestations of a stroke, which are similar, but it is transient in nature. In other words, it resolves within 24 hours, and there's no abnormalities on brain imaging. There's no evidence of any infarction on a CT or MRI scan. For an embolic stroke, as we mentioned, there is an embolic occlusion that typically occurs rather quickly, and the risk factors are atrial fibrillation, so the thrombus forms in the atria, and then it travels into the cerebral vasculature, becomes an embolus, and occludes one of the cerebral arteries. Or that can also occur in the case of rheumatic valve disease or a recent myocardial infarction. The onset of symptoms for an embolic stroke are typically very rapid, as opposed for a thrombotic stroke that develops over hours to days, and the symptoms occur while the patient typically is awake. Usually there's no prior history of a transient ischemic attack, as well as opposed to most individuals with a thrombotic stroke, most likely, or at least a large number of them, will have a prior history of TIAs. Regardless of whether it's a thrombotic or embolic stroke, the clinical manifestations are similar. And it also does depend upon which artery is affected. That is the main factor. It turns out that the middle cerebral artery, or the MCA, is the most commonly affected artery, cerebral artery. Consequently, when we discuss the very characteristic clinical manifestations of a ischemic stroke, they are all based upon the assumption that the middle cerebral artery is the one that is affected. If it is the anterior cerebral artery, or ACA, or the posterior cerebral artery that is affected, that has become thrombosed, then the clinical manifestations are likely to be different. Here we have to make the assumption that it is the middle cerebral artery that is causing the stroke. The obstruction or the thrombus that is in the middle cerebral artery is causing the stroke. That's not a surprise, as we said, because it is the most commonly affected artery, and it is the largest one. So if the MCA is affected, then the clinical manifestations for ischemic stroke include hemiplegia, whereby the upper extremities and the face are usually more affected compared to the lower extremities. That is not a surprise because the MCA supplies the motor cortex, and the motor cortex is made up of large areas that control the upper extremities and the facial muscles as opposed to the lower extremities. So the resulting effect is contralateral motor weakness, because usually only one lateral aspect of the MCA is affected, not both of them. So it is the contralateral side that is affected in terms of the motor weakness and or sensory loss. Talking about sensory loss, that is referred to as hemianesthesia. So you have a hemisensory loss on the opposite side of the body. Similarly, hemianopia, or the loss of vision, or at least visual deficits on the opposite side of the body. And the other most common clinical manifestation for a thrombotic stroke is aphasia, especially if the dominant, which most of us being right-handed, would be the left hemisphere, is involved. So that's Broca's aphasia. Lastly, visuospatial neglect phenomena can also occur if the stroke is on the right side of the brain, or in the right hemisphere. Let's move on to hemorrhagic stroke. So remember that for the thrombotic or embolic stroke, the clinical manifestations are the same, it's just how quickly it develops. For an hemorrhagic stroke, the etiology is an intracranial hemorrhage, and usually the number one risk factor is because of poorly controlled hypertension. The other etiologies include a subarachnoid hemorrhage due to trauma, or a ruptured aneurysm, or a ruptured AVM, arteriovenous malformation. Remember, the risk factors are hypertension that can lead to the intracranial hemorrhage. Interestingly, women who take the oral contraceptive pill have an increased risk of a hemorrhagic stroke as well, and not surprisingly, smoking also increases the risk of a hemorrhagic stroke. The clinical manifestations for a hemorrhagic stroke are very similar to that of a subarachnoid hemorrhage, so we're not going to go through it. In fact, a subarachnoid hemorrhage is a form of a hemorrhagic stroke. Half of all hemorrhagic strokes are subarachnoid hemorrhhage, with the remainder being intracranial hemorrhage into another part of the brain, not the subarachnoid space. But regardless of whether it's hemorrhage into the subarachnoid space or hemorrhage into the remaining brain parenchyma, the clinical manifestations are very similar. I'll ask you to refer to the slides on the clinical manifestations of the subarachnoid hemorrhage. Let's move on to discuss the CNS infection, and we're only going to focus upon bacterial meningitis. The definition of bacterial meningitis is inflammation of the meninges caused by a bacterial infection, either Streptococcus pneumoniae, for example, or Neisseria meningitidis. If you remember from your A&P, the meninges are composed of the dura, arachnoid, and pia mater. Either of those layers, if it gets infected with the bacteria, for example, again, Streptococcus pneumoniae, then a bacterial infection can occur and result in bacterial meningitis. There are, however, viral examples of meningitis. For example, infection with the West Nile virus can cause viral meningitis. In addition, other causes of meningitis include the tertiary stage of syphilis, referred to as neurosyphilis, and syphilis itself is caused by a bacteria that is known as Treponema pallidum. Lastly, tuberculosis can also cause meningitis. The risk factors for bacterial meningitis include the lack of immunization. There's immunization against Streptococcus pneumoniae, for example, as well as Neisseria meningitidis. If there is a lack of immunization against these pathogens, especially in childhood, it increases the risk of developing meningitis later on. The pathogenesis of bacterial meningitis is the hematogenous spread from the nasopharynx to the meninges in the brain, or alternatively direct entry into the meninges via a penetrating head wound. The clinical manifestations of bacterial meningitis include a fever, typically a high fever, 39 degrees Celsius or above, a headache, a stiff neck. Photophobia would be one of the classic clinical manifestations of meningitis, as well as an altered level of consciousness, especially if it is a serious case, resulting in confusion, lethargy, and so forth, seizures, nausea, vomiting, and in the case of Streptococcus pneumoniae being the causative microorganism, a petechial rash on the trunk or the lower extremities, results in meningococcal meningitis, or rather it would be a clinical manifestation of meningococcal meningitis. Let's move on to seizure disorders now. The definition of a seizure disorder is a transient occurrence of neurological signs and symptoms associated with the abnormal firing of the neurons. Most specifically, it is the hypersynchronization of the neurons, which means that all the neurons, or many neurons, are firing at the same time, which would be unusual in the case of a normal functioning brain. The risk factors that can precipitate a seizure include alcohol, illicit drug use or withdrawal, brain injury, a CNS infection such as bacterial meningitis, fever, especially a high fever, various metabolic abnormalities such as metabolic acidosis, and various electrolyte abnormalities, as well as the adverse effects of several medications. Epilepsy is the disorder of the brain characterized by a predisposition to the development of seizures. So if it is a one-off seizure, for example, we wouldn't classify it as epilepsy. Epilepsy is a predisposition of developing seizures. So if seizures develop repeatedly, then we would refer to it as epilepsy. If it is a single seizure, then it would not be classified as epilepsy. There's an old classification system shown here for the seizure disorders, which is no longer in use. Actually, that's a bit of a lie. It is still used, but the transition is towards the new classification system that I'll show you next. In the old classification system, it was divided into partial seizures. What we mean by that is that partial seizures start in one location and then may spread to other location. In other words, the partial seizures may progress to a generalized seizures. And then the partial seizures itself were subdivided into simple partial seizures or complex partial seizures. And there you have the secondarily generalized partial seizures. I'm guessing that the new classification system was developed because there's nothing simple about a seizure disorder. The generalized seizures apparently start over a wide area of the brain. There's no one focal place where it develops. And how do you tell that? Through the EEG. Here's the new classification system for the seizure disorders. It's all based upon where the onset is, so a focal onset makes a lot more sense than a simple partial complex seizure. So a focal onset means it's developed in one location, and then the next level down is the client aware or has the consciousness been impaired. So either aware or impaired awareness, and then is it motor or non-motor, and then does it progress to a generalized seizure. And then we have generalized onset seizure. That's the same as in the old classification system, and there are motor variants that are tonic-clonic, for example, that used to be called grand mal seizures, or other motor type of seizure disorders, and non-motor generalized onset seizure disorders. In the old systems, that would be called a absence seizure. And then we have unknown onset seizure disorders, whereby if you don't really know where the seizure focal onset is, so where it has developed, which location it has developed, then it's classified as unknown onset. If you know the location, then it will be focal onset. If it's widespread, then it will be generalized onset. And then, as I said, motor or non-motor. So I don't want you to focus too much upon this, but this new classification system is what really should be used rather than the old one. Once again, focal onset versus generalized onset, and motor versus non-motor. Here's another flowchart that explains the new classification system for seizures. Focal onset versus generalized onset as determined by the EEG. If it's focal onset, then is the client aware or has impaired awareness? Is it motor versus non-motor? If it's a generalized onset, again, motor versus non-motor variants. And here we have the tonic-clonic seizures. So a generalized tonic-clonic seizure was previously known under the old classification system as a grand mal seizure. It has a tonic phase whereby the muscle becomes stiff, followed by a clonic phase whereby you have this rhythmic, jerky contractions of the muscles. We're now going to switch gears completely and discuss major neurocognitive disorders or dementia. The term major neurocognitive disorders or NCD is now preferred over dementia probably because the term dementia has a whole variety of meanings, especially in the general public. The definition of NCD is a generalized and usually progressive impairment of cognitive function associated with the activities of daily living. The diagnosis of a major neurocognitive disorder requires significant cognitive decline from a previous baseline in one or more cognitive domains, either complex attention, executive functioning, learning and memory, social cognition, or perceptual motor functioning. In terms of the epidemiology of major NCDs, it shows that approximately 1 to 2% of the population develops it by age 65, whereas at age 85, as many as 30% of the population would be diagnosed with major neurocognitive disorder. Major neurocognitive disorder due to Alzheimer's disease is rather uncommon before the age of 60, except in the familial variants, whereby there are specific gene defects. There are several causes of major neurocognitive disorders, or NCDs, but the most common cause is Alzheimer's disease, whereby you have memory impairment, aphasia or difficulty speaking, apraxia or the difficulty in performing tasks or movements when asked, and agnosia, whereby the patient or client has difficulty recognizing and or identifying objects, persons, or sounds using their senses. Other causes of major NCD include dementia with Lewy bodies, frontotemporal dementia, and Huntington's disease, but we're only going to focus upon Alzheimer's disease. There are also vascular causes of major neurocognitive disorders, including multi-infarct dementia that is caused by multiple strokes, for example. Before we go on to discuss Alzheimer's disease in more detail, let's just focus upon this particular table, whereby you see the differences between the early signs of major neurocognitive disorder, Alzheimer's disease, versus normal aging. So the early signs of major NCDs, including forgetting the names of close relations, whereas in normal aging, you can forget the names of acquaintances, especially long-lost acquaintances. On the other hand, you have increased frequency of forgetting in major neurocognitive disorders, the early signs. In normal aging, you have briefly forgetting parts of an experience. In the early signs of major NCD, you are repeating phrases and stories in the same conversation. Normal aging, you're not putting things away properly because you've forgotten, for example. In major neurocognitive disorders, the early signs, you have unpredictable mood changes. And in normal agings, you have mood changes, but they are in response to appropriate causes. And lastly, decreased interest in activities and difficulty making choices is another early sign of a major neurocognitive disorder, in other words, Alzheimer's disease, whereas in normal aging, it is typical to have a few changes in the usual interests, or the interests might change over time. Alzheimer's disease is the most common cause of major neurocognitive disorder, and beyond the NCD criteria, the core features of Alzheimer's disease includes an insidious onset and gradual progression of cognitive and behavioral symptoms. The risk factors for Alzheimer's disease is age. That's the biggest risk factor. There is a genetic component, but if you remember, if Alzheimer's disease develops before the age of 60, then it is the familial variant. But fortunately, in terms of the number of cases, very, very few are of the familial variant, referred to as early onset Alzheimer's disease. In terms of the pathogenesis for Alzheimer's disease, it includes the buildup of senile amyloid plaques, and that is the beta amyloid proteins that are deposited in the brain, causing cortical atrophy and loss of synaptic junctions. In addition to the beta amyloid plaques, you have the neurofibrillary tangles, which are composed of tau amyloid proteins. And lastly, there's also the loss of cholinergic neurons, or neurons that use acetylcholine as the neurotransmitter. In terms of the clinical manifestations of Alzheimer's disease, they include cognitive impairment, for example, deficits in memory, language, abstract reasoning, and executive functioning. That in turn results in various behavioral and psychiatric manifestations, including aphasia, apraxia, and agnosia. Lastly, we just want to highlight that motor manifestations, for example, gait imbalances and incontinence, only occurs at the later stages. Before we move on, I'd just like to do a comparison of dementia versus delirium. Here's a chart, I apologize it not being very clear, that explains the differences between delirium versus dementia. In terms of the onset, delirium develops very acutely, dementia, as we know, develops gradually. If you look at the course of the disease over the day, in delirium there's fluctuating cognitive function and behavior. In dementia it's usually consistent, although there's that so-called sundowning effect whereby the clinical manifestations usually become a little bit more severe as the day progresses, especially just before bedtime. In terms of the level of consciousness in delirium, the consciousness or LOC might be decreased, whereas in dementia it's typically normal. In terms of orientation, in delirium, the client or patient is aware of self but impaired in terms of time and place, whereas in dementia, especially in the latter stages, it's generally impaired. The client or patient is not oriented to self, time, or place. For thought production, in delirium, it is highly disorganized and there's a flight of ideas, meaning your thoughts jump all over the place, whereas in dementia, it is impoverished, meaning a lack of thoughts. As for psychotic features, in delirium there might be delusions and hallucinations, which are fairly common, but in dementia those are minimal, except in the latter stages. In terms of memory, or the state of memory impairment, it's short-term memory impairment for delirium, whereas in dementia it is both short and, especially as we progress, long-term memory impairment as well. As for the prognosis, in delirium it is reversible as long as the underlying cause is treated, for example a UTI in an elderly client, whereas dementia is irreversible, usually irreversible. We're going to move on to now discuss multiple sclerosis. Multiple sclerosis, or MS, is a chronic inflammatory disease of the CNS characterized by relapsing/remitting or progressive neurological symptoms. In terms of the etiology and pathogenesis, MS is most likely an autoimmune-driven inflammation that causes demyelination of the axons and ultimately degeneration of the axons. As for the epidemiology, MS typically occurs at an early onset, usually young adults 17 to 37 years of age, and in terms of the distribution, females are more affected compared to males with a 3-to-1 ratio. The risk factors for the development of MS include various HLAs, that's the genetic component, as well as environmental factors. Interestingly, areas with less sun exposure and lower vitamin D stores, that would be individuals living at high latitudes, have a higher incidence of multiple sclerosis. As for the clinical manifestations of multiple sclerosis, they are quite varied, but include numbness, weakness, and spasticity of the muscles as well as the sensory nerves. Visual disturbances are actually one of the hallmark clinical manifestations, or at least the early clinical manifestations of multiple sclerosis, and that's due to optic neuritis, and that in turn can result in diplopia or double vision. If the nerves that innervate the muscles are affected, that might cause an impaired gait. If the nerves that innervate the inner ear are affected, in terms of axonal demyelination, that vertigo might result. And lastly, if the nerves that innervate the bladder are affected by demyelination, then bladder dysfunction may occur as well. 2 more neurological disorders to go, the first one being Parkinson's disease. The definition of Parkinson's disease is a progressive neurodegenerative motor disorder related to the loss of dopaminergic neurons, in other words, the neurons that produce dopamine in the substantia nigra, that in turn leads to increased inhibition of the cortical motor areas of the brain. As for the epidemiology, Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's disease. The mean onset for Parkinson's disease is 60 years of age, and the risk factors are the family history. Males are more affected compared to females, and there may be a history of head injury. For example, there's a higher incidence of Parkinson's disease in athletes that play in contact sports, especially American football. The clinical manifestations of Parkinson's disease can be summarized by the TRAP acronym, TRAP. T stands for tremor, a resting tremor, R for rigidity of the muscles, A for akinesia or bradykinesia, so difficulty moving or the slow moving of the muscles, and the P stands for postural instability. So please focus upon that particular acronym. It really does describe the clinical manifestations or the typical clinical manifestations of Parkinson's disease. Lastly, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, is a progressive degenerative disease that causes both upper and lower motor neuron symptoms and is ultimately fatal. The median survival from the time of diagnosis is only 3 years, with death typically associated or due to respiratory failure. In terms of the epidemiology and pathogenesis of ALS, it is the idiopathic degeneration of the anterior horn cells of the spinal cord, and if you remember from your A&P, the anterior horn of the spinal cord brings out the motor neurons, and consequently it is a motor neuron disorder. ALS can also affect the cranial nerve nuclei as well as the corticospinal tract. In terms of the clinical manifestations of ALS, they are motor symptoms of the limbs, the lower limbs, as well as bulbar findings, which means that there is difficulty speaking or dysarthria, dysphagia or difficulty swallowing, tongue atrophy and fasciculations of the tongue, facial weakness, and atrophy of various muscles. In the latter stages of ALS, dementia invariably develops as well. Interestingly, there is the sparing of the sensations, so the sensory nerves are not affected, and that probably has to do with the fact that only the anterior and not the posterior horn cells of the spinal cord are affected. So the sensory nerves are spared, the ocular muscles are spared, unlike, for example, in multiple sclerosis, whereby the nerves that innervate the ocular muscles are affected, and also the nerves that innervate the bowel and the bladder are also typically spared as well, so incontinence usually doesn't develop, at least during the initial stages. That brings us to the end of Unit 3, the neurological disorders. Please remember to learn the pathophysiology, which is the etiology, the modifiable, especially risk factors, but you should know all the risk factors, as well as briefly the pathogenesis of those diseases. But most importantly, please focus upon the clinical manifestations of the various diseases, disorders, and conditions that are covered in this slideshow and are listed in the learning outcomes of Unit 3 in the syllabus. Please also remember that you will only be assessed on the diseases, disorders, and conditions that are listed in the learning outcomes for Unit 3. If you have any questions, please contact me via email or your instructor if you require any clarification about the content in this particular unit. Our next lesson is going to be on Unit 4, inflammation, the immune disorders, leukemias, and lymphomas. See you then. Thanks. Bye.